I'm Michael Barringer. I'm the Medical Director for Trauma at Cleveland Regional Medical Center. I'm head of the trauma services here. Well, in 1994 we made a commitment to be different than the usual emergency department and hospital. The trauma system in North Carolina was evolving at that time, so we made a commitment to become part of the trauma system. Being part of a trauma system means that you take people in, you treat them in an organized, consistent fashion, you participate with the region as far as what patients go where, and the main thing is that when someone comes in here, they are taken care of in a very consistent, routine fashion. It's never made up as you go. It's always the same way every time. We have a way that we treat people with certain injuries. We decide early on whether the person is going to be treated here or whether they require a higher level of care. We have a consistent relationship with Carolinas Medical Center, which is a level 1 trauma center. So the flow from here to there is almost seamless, and it is very timely. And trauma care, the main thing that's real important in taking care of a patient is how quickly you take care of the injury and you stabilize the patient, you stop the bleeding, and you make the patient's outcome a whole lot better if you can do those things. When people come into an emergency department that's not organized, it doesn't have all the people ready to take care of them in an organized fashion, there's loss of time, there's what we call sort of secondary injury going on, and the outcome is not as good.
So you follow very rigid protocols here, right?
Yeah, we have strict, we call them guidelines. We have very strict guidelines that we follow, that we watch very closely. We monitor those. Betsy and I, who's a trauma nurse coordinator, we watch every patient that comes in and goes out. We make sure that we follow those guidelines as close as possible. There's some variation that occurs based on a patient's actual injury, but we make sure that if there's any variation in the way that the patient's cared for, that we look at what happened in the system that allowed that to happen, and then we are concurrent in how we deal with that. We go back to the system if it needs to be changed a little bit. We don't do things exactly like we did in 1994 because the way people treat trauma has changed since 1994. Some of the injuries that we have that we would use to keep here, there are more advanced techniques that are now available, that are available at Carolinas Medical Center, so we send those patients there. It's just a process and evolution. It's very kinetic. It's moving all the time. It's something going on all the time, something that changes that we try to adjust to. We have new people come and go, so everybody that enters this facility who participates in trauma care, they're educated, including the doctors, on how we go about taking care of trauma. Obviously, new people bring in new ideas, and we try to incorporate new techniques, new systems into what we're doing. So it's a very fluid type of care, but at any given moment it's pretty rigid. The main thing that we do is we have availability of care immediately. The patient that really benefits from coming to a level 3 is a patient who is critically ill, has something that needs to be taken care of immediately, but may need a higher level of care. For instance, a patient who comes in a car crash who has sustained a head injury, but also has ruptured their spleen and is in shock. Well, that person needs to go to a level 1 trauma center for their head injury, but if we just send them to a level 1 center right away, they could die en route to that facility and not survive. Also, even if they survive to that facility, they could have, in our case, 30-45 minutes of shock, which complicates their head injury. It's called a second injury to the head trauma. So what would happen here typically is a person would come in, they'd be in shock, we'd identify that they had something going on in their abdomen, we would take them immediately to the operating room, we would take care of that injury in the abdomen, such as taking out the spleen, and then upon completing that operation, the patient would be transferred immediately to Carolinas Medical Center. And all that could happen within a period of 2 hours. And we've actually done a study looking at the outcomes of trauma patients who came through this hospital compared to others in the area which are not level 3 trauma centers, and the number of people surviving beyond that expected is twice for our institution as it was for the other institutions. So we have clinical impression as well as we have statistical analysis of our outcomes that show that we're that our outcomes are better. And it just makes sense when you look at what happens to a trauma patient.